Okay, first question is, what to you makes a good surgeon?
Oh my goodness. We were just talking about that this morning because John Okino gave grand rounds about surgical education.
Mm-hmm.
So do you mean a teaching surgeon or a surgeon?
You can answer it in any way that you want.
I think it's somebody who prepares for the operating room by studying their anatomy and maybe these days reviewing surgical procedures. But I guess my thought process is that somebody who is willing to be introspective and really do determined practice to become a better surgeon. In my mind, it doesn't really matter if somebody has the best gifted hands. It's the people that are thoughtful about their surgeries that maybe review them on video if they have a chance to review them on video, or probably just ask what they need to improve upon and work hard to gain their exposure and respect the tissue and make things flow. So in my mind, it's deliberate practice and preparedness getting to the operating room.
I think that's great. Like that short version, deliberate practice. I think that is a really great way to put it. Perfect. So this annual meeting's theme is surgeons as change agents, which I thought was such a great theme. So my question is, how have things changed in your mind over the years, and what changes do you anticipate in the upcoming years in gynecologic surgery?
I think the learners have changed a lot. And we as mentors and educators in the operating room have had to change because the routes have changed, the overall, I guess, embracing the environment for the learner as opposed to teaching in a militaristic fashion. It's kinder and gentler, but it nurtures the learner to the point where the lower volume in some places is probably made up by a better learning environment and also the tools that we have for preparedness. I think that virtual reality and, in a lot of sense, extra reality and models are going to be a big part of learning coming up. We can't make up for experience unless, as I said, deliberate practice, and that comes in cadaver labs or simulations. I think there are so many more tools to become better at surgery rather than just reading the textbooks and the see one, do one, teach one type thing. So I think teachers are more invested because it's a choice, right? I think I've told you so many times that I try to be more patient and think about how many more cases somebody's going to do if I just am patient and let them operate and become the best surgeon they can be. So that's the goal, paying it forward. So I think that that's probably the biggest change. Learning environment, surgical tools, and different opportunities for deliberate practice.
I've been asking a lot of the Eurogyne surgeons who've been doing these interviews what they think is going to change in vaginal surgery, what is going to happen to vaginal surgery in the future. Do you have any thoughts about that?
Well, recently I've been reading a lot about going green. And I think that there are going to be pockets of vaginal surgery training programs that really offer a wonderful native tissue option for their patients, because frankly, we know that mesh probably works better in prospective trials, even maybe for primary prolapse, but patients are going to always want their options. So I believe vaginal surgery, especially in an effort to go green, will become embraced by pockets of surgical practices. And we know that in lower resourced areas that vaginal surgery is what most people do. And so it takes less time. It's still very effective as far as patient subjective outcomes go, but it's not an art that we should lose. We really, as gynecologic surgeons, can't afford to lose the art of vaginal surgery. It's what makes us different, especially as urogynecologists.
I couldn't agree more. Shifting gears a little bit, can you tell me a little bit about what it was like coming into the specialty when women surgeons were uncommon? What was different? Do you still see inequities? And tell us a little bit about who sponsored or mentored you.
I grew up in a home where I was told to be as strong and be the best I could possibly be. And so I don't think that I ever felt a lot of the inequities. And honestly, there were so many people that mentored me, not necessarily the people that I thought would. I think sometimes women are not the best sponsors for other women, even though they want to be, right? But there weren't very many of us as we were starting. And so I remember after my first meeting, which actually I think was either the first or second SGS meeting, I was presenting a fellows award, and David Nichols spoke before me, and Tom Benson also was one of the speakers. And I thought to myself, I have 10 minutes to really shine here. And I want to shine because these are data from our own program. It was a sacrospinous longitudinal study, 243 patients. And I remember what an honor it was. And then after that program, specifically, I remember getting lovely notes from one of my lifelong mentors, Bob Schul. He said the nicest things and encouraged me to become a member of SGS. And so it was very welcoming. And then also Al Addison from Duke also sent me the nicest note and encouraged me to join the society. And the society's always been welcoming. I've loved the society because it's not just been urogynecology, which is great on its own, but embraces all types of subspecialties, but truly the pelvic surgeon.
Well, that's a great segue into the next question, which is what keeps you coming back to SGS meetings?
Well, for a while I didn't go, and I want to go back on a regular basis because it's the beautiful friendships you form over the years. You don't necessarily have to see everybody year after year, but it's like home. It's like coming home to a professional society that welcomed you and really appreciates the gifts of individuals. that make the whole stronger. And so in my mind, that's probably just the best way to be: welcoming, appreciative of others' gifts and knowledge, and willingness to share that knowledge. And so that's what makes SGS special.
Oh, that was perfect. And then last, what's your favorite instrument and why?
Wow. There are so many. I know what my least favorite instruments are. My most favorite instrument and why? Wow, that's so difficult. I just like them all. I love to embrace all tools. I'm a skill hoarder, and
How about in vaginal surgery? What would you say is you cannot live without it, other than a Haney clamp, I guess?
well, it would have to be the Haney needle drivers, because I think that there are very tight spots and specific angles with that they help you with. I think many times we should have the same needle drivers for laparoscopic surgery, and we don't, because whoever was making those needle drivers sort of place the tips in as opposed to placing the tips out. And so I think it's just the perfect curve around the needle, and it allows you to operate in very tight spaces. I know not everybody believes that, but yes, I think deep in the pelvis, the Haney needle drivers are perfect. And we should even have them in our longest instruments for uterosacral vault suspensions. So one other thing I wanted to say about SGS was I was fortunate to be in a group that won the member award in 2006. So the awards were 10 years apart. And you knew that the greatest minds in your field would be at those meetings asking you specific questions, but not really as a challenge, more of a statement of, I love your work and it's made me think. And so I think that type of encouragement and appreciation of good work is really what SGS is all about, and it spans many of the subspecialties. The other thing that I wanted to bring up was there was one year, and I think we were in Charleston, but Dee Fenner and I were asked to highlight some of our surgical tips and tricks in what you would say a surgical tutorial. And of course, I chose the case that made me most humble, which was an extremely difficult bowel dissection off the anterior abdominal wall. It was a lady who was a redo sacrocolpopexy, and she had some hemorrhage that we were able to control. I just remember some of the older surgeons were like, under their breath, how could a master surgeon like that show something so difficult to do and still make it look difficult? And I thought to myself, it's okay if you watch really good surgeons do great surgery, but it's when you see great surgeons, and again, I shouldn't say that, because I'm a thoughtful surgeon, maybe not a great surgeon, but to be able to show your work and say, hey, that was really hard, was probably inspiring to others to say, we can do this, and it's not always going to be easy, but it's worthwhile. And so for that patient who I still hear from today, it made a world of difference.